Hello, everybody. My name's Geetha Pinto. I'm one of the Roper Coastal Cardiology cardiologists, and I also am the Director of Heart Failure for the Roper Healthcare, St. Francis Healthcare System. And today I'm going to be talking to y'all about the diagnosis and management of heart failure. There's a lot going on in this space, so hopefully I can give you a good overall view, although, there's a lot. So I'm happy to answer any questions after the presentation. Okay, all right. Okay. So heart failure is a clinical syndrome, and it involves both symptoms and signs of heart failure. So the symptoms are dyspnea, lower extremity edema, orthopnea, and signs of heart failure, which are peripheral edema, jugular venous distension, pulmonary congestion. And in addition to that, we see both structural and functional problems with the heart muscle itself. And so this can be supported by biomarkers, like the most common one that we use is NT-proBNP or BNP in some assays, but at Roper we solely use NT-proBNPs, which is preferred because of the use of sacubitril valsartan, which can make those numbers a little different. And then the syndrome thus leads to impaired ventricular filling or ejection of blood, and that leads to a decreased stroke volume, which then leads to a decreased cardiac output, which then leads to all the symptoms we've talked about. Heart failure is classified in many different ways. The most familiar classification we have here is based on ejection fraction. So if you have I'm sorry? Oh, I'm sorry. Here we go. I have two things going on at the same time here. I'm sorry. So heart failure with reduced ejection fraction is defined as heart failure in the setting of an ejection fraction of less than or equal to 40%, plus an elevated NT-proBNP along with signs and symptoms of congestive heart failure. Heart failure with preserved ejection fraction, which we're all familiar with, is heart failure with an EF of greater than or equal to 50%. So technically normal ejection fraction, but certainly filling pressures and cardiac output are different. So people get a little bit of confusion between, like, why is the EF normal? The EF can be normal in any situation, but we mainly look for ventricular filling that's abnormal, and also whether the output is abnormal. And then the newer entities that have been introduced are the heart failure with mid-range LV function or mildly reduced EF. And that's anywhere between 41 and 49% ejection fraction. And it's hard to know at this point what this entity really behaves as. In some features, it has supporting evidence that you can treat it as heart failure with reduced ejection fraction. And then in other instances, patients do better with therapies that are used for heart failure with preserved ejection fraction. So this is kind of the crossover of ejection fraction. And the newest entity we've added is, what do we do with people who've had heart failure 10 years ago? They had a low EF, put them on GDMT, and they're back to normal. So do we just say you're cured, you're fully better, go home? Well, we do think that they are still at risk for future decompensation and recurrence in systolic dysfunction, and so we've classified them as heart failure with recovered ejection fraction. We continue to monitor them closely, follow up echoes, continue risk factor modification, and so we at least have a category for patients who have had a great outcome, but we still are in surveillance. And so the other way heart failure can be classified is based on stages. And this was mainly created to identify people that were at risk. I mean, yes, so a patient comes to you, they're already in heart failure. We know mostly what to do with them. But what about identifying pre-heart failure? What about identifying people before they get heart failure? It's sort of a prevention of heart failure. So that's where the introduction of stages of heart failure came into play. So stages of heart failure, stage A are people that are at risk for development of heart failure in the future, whether it be heart failure with reduced or preserved ejection fraction. And these are most commonly patients with uncontrolled hypertension, being the biggest risk factor, obesity, diabetes. So when patients have these risk factors, they're in stage A heart failure. They haven't had heart failure yet, but they definitely are at increased risk for development over time. And this is where you as the primary care physician have a huge role in preventing the trajectory down to stage C and D. Stage B heart failure are people who have manifestation of either systolic or diastolic dysfunction, but have yet to have the symptoms of heart failure, which include pulmonary vascular congestion, peripheral edema, dyspnea, orthopnea. Stage C are patients who have signs and symptoms of heart failure and dysfunction, systolic or diastolic. And so these are the patients that typically get admitted to the hospital with volume overload, and we diurese them, they get better, they go back to a normal-ish life until their next hospitalization. And then stage D are the patients who are mostly with advanced heart failure. They have signs and symptoms even at rest, and they need to be considered strongly for mechanical circulatory strategies, including inotropic support, if you're doing milrinone or home dobutamine, eventually LVAD and transplant. So nobody wants to be in stage D. The good news is a lot of our current GDMT has actually reduced the number of people with at least heart failure with reduced ejection fraction going to stage D, but that's sort of end-stage cancer, stage 4 metastatic cancer for heart failure. And then we also classify heart failure based on symptoms. So NYHA classes, which I think we were all more familiar with, are patients who will bounce around from stage 1, class 1 to class 4 based on their symptoms. And so class 1 patients are those who have the phenotype of heart failure, but they don't have any symptoms. So they have LV dysfunction, diastolic dysfunction with elevated filling pressures, but they don't have symptoms per se. And class 2 patients are those who have symptoms with exercise, regular activity, but they're okay at rest. They can climb a couple of flights of stairs, they do get tired, they're limited, but not terribly so.
Hold on a second. Let me help you out.
I'm sorry. I'm
That's okay.
so sorry.
If you hand me the clicker, I'll do the clicking and you do the talking. How's that?
I think I'm giving the presentation to myself. Okay. Thank you, Valerie. Anyway, the NYHA classes are class 1 through 4, and they're based on symptoms. So patients can bounce between any of these classes. Most commonly, we see class 2 and 3. I say class 1 is an undefined population, right? Like, we don't know who those people are. They might have the diastolic or systolic dysfunction, but they haven't yet presented to us. So, but class 2 and 3 are people we see in the hospital or in your office that have symptoms. Class 4, again, these people are severely limited in their exercise capacity, and they have symptoms even sometimes at rest. And our goal is to hopefully keep everybody at class 1 and class 2. Next slide. So the diagnostic approach of heart failure. So the most important thing is a history and physical. Believe it or not, in today's age of AI, we still use a history and physical. I find it very important. I pick up a lot of heart murmurs that computers don't pick up. It's still a very important way to pick up the story of what exactly happened, how did they present. So a history and physical is very important in diagnosing heart failure. And of course, then we can use biomarkers, most importantly, NT-proBNP that we use at Roper. And then the next step would be obviously to get an echocardiogram either as an inpatient or an outpatient to assess cardiac structure and function. And then EKGs would be helpful to see if this patient has had a prior myocardial infarction or they're in atrial fibrillation, which is a very common scenario in patients with heart failure. And then for heart failure with mid-range and preserved ejection fraction, this is where the art of medicine comes in. This is where you have to look a little further into your patient's symptoms and say, is this really heart failure, or is this because they're overweight or deconditioned, or they've just come out of the hospital and had a whole bunch of other things, or is this some other disease process? Is this a pulmonary process? And so in order to qualify for heart failure with mid-range or preserved ejection fraction, you must have elevated LV filling pressures. A neat trick is to look at the echocardiogram report and not just look at the conclusion, but look into the little data, the whole rows of data that you see, and you see the E to E prime ratio. The E to E prime ratio is a sign of elevated filling pressures. If you see an E to E prime ratio greater than or equal to 14 or 15, that's an elevated filling pressure. Now, those patients may not have heart failure. You have to have signs and symptoms of heart failure. So you just can't have diastolic dysfunction. But when you look at that report and you say, this patient's really short of breath, they have edema, but it could be that they're just overweight or obese. And if you look at the echo and it says E to E prime greater than 15 or 14, you're like, yeah, there may be more to the story. And at that point, you can check an NT-proBNP. And if that's elevated, then you're heading towards the diagnosis of heart failure. But on the flip side, if you see diastolic dysfunction on your echocardiogram, that does not mean that the patient has heart failure. People can have elevated LV filling pressures, manage them well, and still not have any symptoms. So that's where sometimes we get consults saying, oh my God, the patient has diastolic dysfunction. Do they have heart failure? No, they have to have signs and symptoms of heart failure. Next slide. So this is a schematic looking at the various causes of dyspnea. Of course, we look for the cardiac causes, cardiomyopathies, coronary artery disease, valvular heart disease, pericardial disease, arrhythmias, most commonly being atrial fibrillation. But you as the primary care physician or provider has a lot of work to do to kind of look and see what exactly is causing the shortness of breath. Is it pulmonary disease? Is it obstructive disease, restrictive disease? Is it neuromuscular in nature? Are they deconditioned? Are they just anxious? I think last week I saw a patient who just could not breathe. She said, I just can't breathe. Her oxygen sats were normal. She just couldn't breathe. And I checked an NT-proBNP, I checked an echocardiogram, I checked a CT scan for P protocol. Everything was negative. D-dimer was negative the week before. And I said, okay, this is strange. I mean, does she have coronary artery disease? I did a stress test, that was negative. And she was just sitting, and then I looked at her husband, and it's so important to look at the partner when you investigate what's going on. And he said, she's anxious. And I said, okay, well, we'll move our conversation a little differently. And turns out her son recently was in jail, and there were so many other things going on. So we have to be investigators, right? Like it takes a lot more than just saying, here's the history, here's the physical, here are the labs, and go on. We have to be psychiatrists sometimes. We have to be friends to our patients sometimes. There's a lot going on. So anxiety can be why some of our patients may be short of breath. And then edema, the good old edema, right? You see someone coming with edema and you're like, oh my God, okay, what can this be, right? So calcium channel blockers, gabapentin, they all can cause edema. So you'd look at that first. Patients taking NSAIDs, high doses of NSAIDs can cause edema. Steroids, very common. I've had patients with steroids who say, no, I'm in heart failure. And I say, no, I know it's your steroids. And so, but guess what? Diuretics work for both. So, if you have to win, give them some Lasix, right? And then you have people who are who have protein enteropathies, protein loss for various reasons, and they present with heart failure. And very commonly, we see patients in the hospital who have edema all the way up to their waist, and you're like, this is not really looking like heart failure, because usually heart failure tends to gravitate towards the lungs, the legs, but it's quite possible that if a patient has compensated long enough as an outpatient, they'll have all that fluid build up. But it's important to get a UA and see how much protein they're spilling. You know, if they have greater than 3 grams of protein, it's most likely that their edema is related to nephrotic syndrome. And so the diagnostic scoring, so HFrEF, or heart failure with reduced systolic dysfunction, pretty easy to diagnose. You get the echo, the EF is less than or equal to 40%, the NT-proBNP is elevated, straightforward signs, symptoms, good. HFpEF is the challenge, and it continues to be a challenge. So we've come up with different ways to try to figure out, is this patient really short of breath or having peripheral edema because of cardiac etiologies or non-cardiac etiologies? So there's 2 scoring systems that have helped us understand this, and you know, I don't recommend anybody commit this to memory or anything like this. I mean, hopefully AI will generate these scores for us in the future. At least that's the promise. But if you look and see, and I find the HFpEF score very useful. That's the next slide. And basically, anybody who's heavy, who has atrial fibrillation, huge risk for heart failure, who has pulmonary hypertension, or elderly people, or I don't know about elderly, I mean, I think they're older, age 60 is still young in cardiac disease. And then if you looked at the echocardiogram and you see filling pressures are elevated, you know, you add this score up and you say, oh, this looks more like heart failure with preserved ejection fraction. So, you know, you may not write this score down, but it gives you a background as to screening for patients and seeing, okay, this may be more likely. So if you have a score of 6 or more, you're like, this is highly likely that this is heart failure. And then this is the HFA-PEF score. I find it highly confusing and very busy. But that's to say that it's not easy to diagnose heart failure with preserved ejection fraction. We as cardiologists continue to struggle. We're always trying to say, you know, if we could get a right heart cath on everybody, see the filling pressures, that would be easy, right? Like you come in, you know, you're in the office, you could do a right heart cath, you're good. But you can't do that, right? I mean, so there's some non-invasive ways of checking for outpatients with elevated filling pressures. There's some technology that are in the studies. But that being said, you don't have that convenience. So it's your detective work to put all this data together and try to figure out heart failure with preserved ejection fraction. And quite often when patients are admitted to the hospital and we've diuresed them, they're still short of breath, or we've diuresed them and their renal function goes up, we're like, yeah, let's just do a right heart cath and figure it out. So right heart caths are very helpful, but in lieu of right heart caths, in your practice, using some of these metrics might help you. Next slide. So any questions about the diagnosis of heart failure? Okay. So we'll move forward with the management of heart failure. So heart failure with reduced ejection fraction, straightforward. We have something called the 4 pillars. All of these drugs have class 1 indication, meaning they have been supported by multiple randomized controlled trials that these drugs improve the heart failure outcomes, including hospitalizations, cardiovascular mortality, and sometimes even all-cause mortality. So these are slam dunk drugs. You see a heart failure with reduced ejection fraction, these are the 4 drugs or classification of drugs you need to put them on. End of story, right? And then you send them for prior authorization, and you know, and so then the battle begins. The cost of these drugs, right? Mainly the SGLT2 inhibitors. Granted, they are by far, I find, the #1 drug we reach out for heart failure with preserved and reduced ejection fraction. But trying to get a prior authorization in patients who need this drug very badly is difficult. So, and cost of medications is also a big deal here. But the 4 classes of drugs that we use are RAS inhibitors, and the most recommended one is Entresto, sacubitril valsartan. I'll tell you, it wasn't generic until I think earlier this year, and now it's generic. So patients are able to afford it a lot more. I go to Cost Plus Drugs. Have you guys used that? No? Okay, yeah. So it's a fantastic resource. Anytime I want to find out how much does this drug truly cost to manufacture, I go to costplusdrugs.com. If it's a generic drug, I put the name in there. And then right there I show my patient, look, this is Entresto. It costs about $30 a month to manufacture and get to you. So whatever your pharmacy and your prescription plan is charging you, it's all the negotiations that are going on in the background for profit margins. And so it's very helpful. Entresto is available at Cost Plus Drugs for about $30 a month. And I think commercial insurances and I think even Medicare has slashed the prices. But that just happened recently. In terms of beta blockers, there's only 3 beta blockers, types of beta blockers that have been recommended for heart failure with reduced ejection fraction, carvedilol being the mainstay. But metoprolol and bisoprolol also have good data supporting them. Metoprolol has to be the succinate version and not the tartrate version. So if you have a patient on tartrate, you would have to switch them to the succinate version. And then there's mineralocorticoid receptor agonists, or we shortly call them MRAs, spironolactone and eplerenone, and the newest one is finerenone. I think you all may be familiar with that, used in diabetes and kidney disease, but now heart failure as well, but not for heart failure with reduced ejection fraction. We do not have that data yet. And then mainstay are SGLT2 inhibitors. So I believe Cost Plus Drugs has an SGLT2 inhibitor that, correct? Is that? Yeah, is it Farxiga generic? There was another one too, but so that's an avenue too that patients can choose to get. And so diuretics is a class 1 indication, but it does not reduce mortality. Okay, so diuretics is mainly to prevent congestion, reduce hospitalization. And so furosemide is used very commonly. I have started using more bumetanide now than furosemide because I do find, and this is proven that the bioavailability, the GI bioavailability of bumetanide and torsemide are twice that of furosemide. And so, especially in patients with heart failure, eventually they develop gut edema and their gut no longer absorbs these medications well. And so when you're starting with a bioavailability about 40 to 50% with furosemide, when they're really needing the drug the most, it's about 10 to 20% because their gut doesn't edema. And that's why they come back to the hospital volume overloaded. And they're compliant. They say, I do everything right. So, but it's because their guts aren't absorbing as much. But bumetanide and torsemide have a much better bioavailability and gut absorption. So we've switched to using that more often these days. Intravenously, though, the bioavailability is the same. Once you dump it into the circulatory system, whether it be IV torsemide, IV bumetanide, IV Lasix, all the same. So you'll probably see inpatient will use Lasix and then we say, oh, well, we're going to send you home on bumetanide. And then the newest of this iteration is subcutaneous Furosix. I think many of you use it in your offices, right? No? Okay, all right. So subcutaneous Furosix is a very neat way of trying to diurese a patient as an outpatient. And so you have a patient doing great over the last couple weeks, starting to fill up with fluid, short of breath, and you're like, yeah, I really don't want to. You're not in an extremis where I need to send you to the hospital, but how can I kind of get you out of this situation where we can have your gut start absorbing better your oral pills? And so subcutaneous Lasix comes in a little cassette, and it's 80 milligrams sub-Q of Lasix, and it gives the first 30 milligrams in a bolus. And I wish I had a schematic, but, and then it gives 10, 10, 10, 10 over the next 5 hours. So it's kind of a slow release Lasix, and patients will just put a cassette like this on their abdomen, and it's a very small needle. It's very straightforward. I tell them to all go to YouTube and look at how to do it. And they have to not move very much with this. So they can go back and forth to the bathroom, but if you move too much, if you're trying to, exercise, it's not going to work because the whole cartridge will fall off. But you give them that, and it works exactly like intravenous Lasix. And so they have that crazy diuresis, like a bolus, and I do it for like 3 days in a row. And I don't even have to change the oral Lasix, which is not working anyway, the bumetanide. They're like, well, should I stop the oral? No, you can do whatever you want with it. Some people feel more comfortable saying, okay, just stop the oral pill while you're taking the subcutaneous. And so we just give them that for 3 days, and then they go back to their normal regimen. So I think it's very, very effective. The beauty about that is also that previously, if we needed to diurese someone as an outpatient, we would throw metolazone on them and say, okay, take metolazone along with Lasix, and that precipitously changes the electrolytes. The potassium goes to 2. You're like, oh my God, the potassium's 2. You have to follow the electrolytes very closely. Sub-Q Lasix, nothing. I may say, go ahead and take an additional dose of oral potassium while you're on this, but it's a much gentler way of diuresing the patient. So you really don't have to check a creatinine, you don't have to check potassium or anything like that. So very useful. I do have some patients take it on a weekly basis because it seems to give them that little push, dry them out, and then they go back to their oral. Of course, cost is a big issue. Over the last 2 years, it's improved in coverage quite a bit. And the cartridge is a little bulky, and so some patients find it daunting, but they're coming in, as everything else, a sub-Q injections coming in the next few months. So that I think would be a lot more preferred. Next slide. And so this is for stage C heart failure with reduced ejection fraction. So the mainstay are the 4 drugs. And then what about some of the other issues that come around? So if you have a patient who's African American and that still has very high blood pressures, a combination of isodrel and hydralazine actually improves outcomes in this group of patients. So it's important to really get those blood pressures very nicely down because that is the #1 risk factor for heart failure exacerbations. And then there's a couple of other drugs, ivabradine and vericiguat. Ivabradine is useful in the reduction of hospitalizations but has no data in terms of mortality or cardiovascular risk mortality benefit. And so it's helpful in patients with reduced ejection fraction who are just like tacking away and you're like, my God, your heart rate is 90 and I have you on 25 or 50 of carvedilol, and you start a little bit of Corlanor or ivabradine twice a day, up titrated for a heart rate of 70, and patients feel better. So, there's something said to patients actually feeling better, right? Like we always look at, do they live longer? Like your patient cares sort of about living longer, but they more immediately care about, can I feel better? And so I'm happy that these days many of our studies are looking to see, is it making you feel better as well? So ivabradine does make people feel better. And so it's very helpful. It's a twice-a-day drug. And then vericiguat is a guanylyl cyclase vasodilator. I don't use it often. It's helpful in people who is the last straw sort of situation where you're like, well, I've tried everything else. Their blood pressure's not great. Their kidney function's not great. And so we'll try this medication. But I don't think the cost sometimes justifies the benefit in using this drug. But you'll probably see this. And they have just one study. So, if we want to use something, we need to see more data. So that's this is just to show you where we've come from and where we're at now, right? So when we first started all of this, all we had was digoxin. All we had was Lasix. But as we've gotten better and better with GDMT, we've reduced the risk of hospitalizations and cardiovascular mortality in these patients by about 40 to 50% if we can get them on all this GDMT. So it's so important to get your patients on the 4 pillars and titrate to the max tolerated doses. Because this is where we're at, is, I see that as a witness. Even 6 years ago, we'd be like, oh my God, these patients are not doing well. I wouldn't have a whole lot of different ways to improve their heart failure, just beta blocker, Entresto was out then. But since SGLT2 inhibitors came into play, and we've seen a difference in how we're managing these patients, and less of these patients are getting admitted over and over again for heart failure exacerbations. So it's really important to put patients with reduced ejection fraction on the 4 pillars, titrate the other medications based on symptoms and specific clinical conditions, because you're actually going to make them A, feel better, live longer. So, next slide. So what about device therapies? Of course, if you have cardiology, you have interventional cardiologists, and they're going to want to put in a device in you, so or electrophysiologists. But the good news is that we have made innovations in device therapies for heart failure with reduced ejection fraction. Most commonly is cardiac resynchronization therapy. So these are patients with an ejection fraction less than 35%, and they have a left bundle branch block, and they have a lot of dyssynchrony on their echocardiogram. And so basically putting in a bi-V pacemaker, sometimes defibrillator, if they qualify for it, definitely improves outcomes in these patients. And so we always look for left bundle branch block. Does this patient have a left bundle branch block? And if they do, and the ejection fraction is less than 35%, most of them will improve. I'd say about 50% of them would improve with a biventricular device. ICDs, they of course don't help any symptoms, but they do prolong life in patients with heart failure with reduced ejection fraction. The newer data suggests that this is probably more beneficial in patients with ischemic heart disease and not so beneficial in patients with non-ischemic cardiomyopathies. And I think that has a lot to say with how well we've done with GDMT. When the first studies of ICDs came out, we didn't have Entresto, we did not have SGLT2 inhibitors, we didn't really up titrate to the max dose. So these medications have really changed the trajectory in such that non-ischemics, I find it hard-pressed to put in a defibrillator. In fact, the CMS guidelines are you have to wait 3 months, full core GDMT, and then put in a defibrillator of the ejection fraction. I actually wait 8-9 months. As long as they're not at an increased risk of sudden cardiac death, I make sure they're not having evidence of any ventricular tachycardia or any abnormal EKGs that tell me they're probably at risk for QT prolongation and sudden cardiac death. But that being said, we can prolong medical therapy, and there are times where patients will develop a much improved ejection fraction, 45%, 50%, and they don't need an ICD. An ICD is a permanent device in your chest, So if we can avoid that, that's helpful. And the good news is that the data is suggesting that if it's non-ischemic, we're okay. And then we have transcatheter mitral valve edge-to-edge repair for severe mitral regurgitation and heart failure with reduced ejection fraction. So these patients have dilated cardiomyopathies, and part of that pathophysiology is that they have such a wide annulus, their mitral valve is really stretched out, and they have severe mitral regurgitation. And so and then the CardioMEMS heart failure system, which is a continuous outpatient PA monitoring system. So this is a swan you wear as an outpatient. You just don't have all the external connections. It's basically a PA sensor that is inserted in the hospital, and we put it in the left pulmonary artery, left branch, and it constantly monitors PA pressures. And so I'll talk about that in just a second. So this is, next slide. Actually, slide before that, please. Yeah. So if you can just play the... No? it's too bad. No? No? Okay. All right. So, so this is basically the edge-to-edge repair. So it's a device that we insert, and then we go up to the mitral valve. We cross over onto the left atrium, and we go up to the mitral valve. And then if this is the mitral valve, we put a clip to cinch the two leaflets right where the valve meets, the leaflets meet. And so we go from severe mitral regurgitation to mild or moderate mitral regurgitation. It's not a cure. It's not going to say you're going to get no mitral regurgitation. But these patients benefit a lot because we've reduced that volume that's going back into their lungs. And so, the perfect storm is someone's blood pressure goes up even by 30 millimeters of mercury. They can go into flash pulmonary edema, especially if they have severe mitral regurgitation. So we reduce the mitral regurgitation, and these patients have reduction in hospitalizations, not mortality. They're very sick patients. I mean, very few things. This is not like the first thing we do when we see a patient with heart failure with reduced ejection fraction. This is like a fourth or a fifth thing we look at and say, okay, this patient keeps coming in with heart failure. Do they have severe mitral regurgitation? We can do a catheter edge-to-edge repair. We do this at Roper. So we have done close to 30 cases so far over the last couple of years. So this is available to our patients at Roper. And so what we usually do is we see patients who keep coming in for heart failure. We have a valve conference every Tuesday morning. We meet, and cardiologists, and if y'all want, y'all can submit cases for us to say, listen, this patient has severe MR, I'm not sure what to do. And actually, they could have any valve issue, and we'll discuss the patient, determine all the techniques we have to help the patients, whether it's a TAVR valve to fix the aortic valve or it's a mitral clip. And then we have surgeons, we have cardiologists there that are with us. We have a valve expert, Dr. Blaise Carabello. Have you all met him? Yeah, he's with us as well. And so we'll triage the patient to various percutaneous or open repair strategies for these patients. So it's very neat. I think Roper is doing a lot of good work in the valve area. Next slide. And so this is the CardioMEMS heart failure system. And so this is the outpatient PA catheter. So we basically do a right heart cath, like we're looking for PA pressures, and then we insert the little device you see up there, the one that has the two loops, into the pulmonary artery. We insert it. We kind of do a baseline for their measurements, and then we send the patient home with this pillow. It's a huge pillow, by the way. But the patients lie down on this pillow, and they have a little transmission box in the side. And every day they'll lie on this pillow. They have to lie there for about a minute, and that syncs up their pressures. And that data is transmitted to an online website, merlin.net. And we have PAs and a heart failure nurse at Roper that looks into the data, and they monitor the PA diastolic pressures. And so if the PA diastolic, say, at the baseline, that PA diastolic was 24 millimeters of mercury, and all of a sudden it goes up to like 30 millimeters of mercury, they're watching. And then if it stays at 30, they call the patient, they say, hey, your PA pressures are up, let's go ahead and have you take a couple of extra doses of Lasix over the next couple of days, because the PA pressures go up before anything else happens. So we kind of catch these patients way ahead of time. So the PA pressure goes up, and then patients develop shortness of breath. And by the time patients have edema, I think they're like 7 or 8 pounds already up. So it's even before the weight goes up, we can see signals on this. It's a very, very useful device. We have this available at Roper. We've placed about 24. We just started doing this. The pivotal trial was released in 2011, but it's taken us so long because the device was very expensive. So, Roper had to buy the device, and then the cost of the device was way more than the cost of justifying the hospitalization. So in order to put it in, we would be spending more. So, but that cost adjusted over time, and now it's more it's more cost effective to put these devices in. So many institutions continue to not put this in, but we're lucky that we've pushed for it and our patients have done well with it. Any questions about this? No? Okay. I'm sorry? 24. We have up to 24 patients now. Yeah. Yes and no. I mean, I think this is very helpful for more chronic management of patients who are compliant in some ways and not in others. And I think that it helps assess PA pressures before the patient actually gains significant amount of weight from it, if that makes sense. So when the PA pressures go up, you see a sudden rise in the PA pressure that may not have translated to 2 to 3 pounds of weight gain yet. So we're able to do that. And I think that weight gain sometimes can be challenging. Patients' weights fluctuate because of salty diets and all of that. Is it really related to a PA pressure going up, or is it just net volume overload? It's hard to know. So this device, I think, is more sensitive to changes in PA pressures, and that's the helpful part to us. So the MACE data, no. So it does not reduce cardiovascular outcomes yet, but there were 3 trials. One was the CHAMPION-HF, which showed reduction in hospitalizations. And when they went back and looked at it, they looked at cardiovascular and overall mortality, and they said that the arm that had the device was much better taken care of because they had a lot more interventions, they had a lot more connections with the team. And so, as you know, heart failure care is a lot of follow-ups, right? And the standard arm didn't really have all that sort of intense therapy. So they said, we can't really say that, it reduces heart failure hospitalizations, but we can't really use the data for MACE. The second trial, and I'm blanking on the name of that trial, was I think the GUIDE-HF trial, I believe, and that was done right at the pandemic, and that disrupted everything. So they couldn't really use that data. But the most recent trial, called the MONITOR-HF trial, that has shown reduction in cardiovascular mortality. So I think the guidelines, currently it's a 2B indication to place these devices. I think in the next iteration of the guidelines, it will go to 2A, potentially class 1, potentially, but probably 2A. So, great question. Next slide. So drug therapy. So drug therapy is the cornerstone of management of heart failure with preserved ejection fraction. SGLT2 inhibitors, once again, out the door. Multiple trials have now shown reduction in hospitalizations and cardiovascular mortality. It's currently still a 2A indication, soon to be a class 1 indication for the management of heart failure. But all other therapies have been challenging. I mean, none of the management strategies for heart failure with preserved ejection fraction have been slam dunk. And so, we use a combination of diuretics, Entresto, ARNIs, ARBs, and MRAs that may be helpful, but mainly to reduce hospitalizations. MACE data is still lacking. And so, if we can go to the next slide. And so SGLT2 inhibitors, I don't need to beat on this anymore, but it's nifty because the way it works, it's a sodium and glucose co-transporter. So when you inhibit the sodium glucose co-transporter in the renal tubules, you're getting both a natriuresis and a diuresis. And that's the best type of diuretic. And so it's been very helpful, and it doesn't cause much disruption in renal function. We do see a little bit of a bump in creatinine, but no major electrolyte shifts. And so we've had a lot of benefit. It has less side effects, such as gout, and so we use it a lot more. But I'm thankful to know that the coverage of Farxiga is getting better What's the cost?
It's a lot. It's $590 a year, but they go completely generic later this year, so it should be lost.
A lot less, yeah. Okay, wonderful. So, okay, next slide. And so, this is the data from the Emperor Preserve trial, which showed that there was a 21% reduction in cardiovascular death and hospitalization with empagliflozin, which is Jardiance. And so, these are some large trials. If you go on to the next slide. If you looked at all the various drug classes and studies that have been looked at, the only ones that have shown to reduce mortality, hospitalization, cardiovascular mortality are the SGLT2 inhibitors. And so this is why I think it will get a class 1 indication for heart failure with preserved ejection fraction coming up. It's already a class 1 indication for heart failure with reduced ejection fraction. Okay, next slide. Next slide, okay. Yep. And so the newest kid on the block is finerenone. I think you all are familiar with it because you use it for diabetes and chronic kidney disease, is that right? But for us, we are now being asked to use it by drug reps, of course, for heart failure with more mid-range. So the ejection fraction cutoff is greater than or equal to 40 and above. So I'd say this is more like a mid-range in preserved EF. And I guess the advantage of this, and I have yet to see it, I've used it maybe in a couple of patients, is that it's a non-steroidal MRA. And so you don't get the sex hormone side effects such as gynecomastia, erectile dysfunction that can be seen with spironolactone and eplerenone. But I'm not sure I buy that just yet. I mean, I've had a lot of success with eplerenone. Patients don't develop gynecomastia. I haven't seen too many complaints about sexual dysfunction on these medications, mainly because if you think about it, these heart failure patients are on so many other medications that are likely causing their sexual dysfunction. I think it's hard to tell them, like, this is the one drug we switch and your sexual dysfunction is going to go away, So I think the company seems to think it's a big deal, but we have yet to see that. But it has, and it's been FDA approved, but it's not yet in the guidelines, so we'll have to see where that goes. Next slide. Okay. So what about devices in heart failure with preserved ejection fraction? Well, CardioMEMS is the only approved device for heart failure with preserved ejection fraction, and this is the PA sensor, the internal PA sensor I showed you that you have to lie on a pillow. And the MACE data is not yet there, although I think that with the latest trial being released, we may have that. But it's a very helpful device to have. It does have some limitations. Patients get very tired of having to lay on the pillow every day and have to do it. So when they first get admitted with a heart failure hospitalization, we see a lot of compliance. They're like, yeah, I don't want to get hospitalized again, so they lay on the pillow every day. And then after 30 days, we switch them to a every other day or Monday, Wednesday, Friday schedule to check on them. And then, the longer time goes by, it's harder to get them to do it because they feel good, and so, all right. Next slide. So what about GLP-1 receptor agonists, right? You all just had a talk on that, and it's all the hype now. I'll say that it's very helpful in patients with obesity and heart failure with preserved ejection fraction, mainly because it causes such a drastic reduction in weight loss that all the dynamics get better in these patients, right? Their diabetes gets better, their blood pressure gets better, their metabolic syndrome gets better. And so we also see that their heart failure gets better too. So if you can go to the next slide. So this was the trial that looked at semaglutide. So we have two GLP-1 RAs, or I think tirzepatide is a GLP-GIP combination. But semaglutide didn't do an outcomes trial. Of course, they always want to do baby steps before they say the outcomes, because once you say there's no outcomes, it's over, right, for these companies. So, but basically they looked at some of the surrogates, like a KCCQ, 30-minute walk, a 6-minute walk test, and inflammatory markers. And there was a significant reduction, an improvement in all of these markers. So we'll have to see where this goes next. I mean, this is definitely data that's helpful. If we go to the next slide. And if we looked at tirzepatide, there was definitely, some signal towards reduction in outcomes as well. But it's hard to know where they fall outside of the scenario of non-obesity patients with heart failure. And that's where I think we've got a lot more work to do. Yes, if their BMI is above 30 and they have heart failure, it's almost a no-brainer to put them on GLP-1s. But what about those patients who obesity is not their problem? And I think that data needs to be sorted out. Next slide. And so I think this is just showing tirzepatide and change from baseline for the KCCQ. So patients on tirzepatide and heart failure with preserved ejection fraction had a much improved quality of life. Next slide. So in summary, in terms of GLP-1 receptor agonists, there's no approved GLP-1 agonist for heart failure with either preserved or reduced ejection fraction. It has been very helpful in heart failure with preserved ejection fraction, especially if their BMI is above 30. Heart failure with reduced ejection fraction, we're not sure yet. I think that was very mixed data, so we don't use it unless they have other indications like diabetes or obesity. Then that's something we would recommend. And in terms of, but we do have the indication for cardiovascular risk reduction in patients with prior MI, stroke, PAD, and a BMI above 27. So I regularly put patients on semaglutide if I have any of these comorbidities. Next slide. So I guess I did want to touch on amyloidosis. It's the new hot topic in heart failure. I'm sure a lot of your patients see the ads on TV for amyloidosis. Ask your doctor if you have amyloidosis. But cardiac amyloidosis is in the forefront now. We always had cardiac amyloidosis. The issue was that we didn't have any treatments for cardiac amyloidosis. And so once we made the diagnosis, it would be like, well, we don't have anything to offer you at this point. So, but with the improvement in diagnostic capabilities and treatment capabilities, cardiac amyloidosis has become a very important thing to know in terms of heart failure. And so cardiac amyloidosis is basically extracellular misfolded protein deposition in the heart muscle. And that causes either diastolic or systolic dysfunction. More commonly causes diastolic dysfunction, which then can lead to heart failure with preserved ejection fraction, but more of the end-stage amyloidosis can cause systolic dysfunction, and we can pick it up there as well. The two common forms of amyloidosis that involve the heart are AL and ATTR amyloidosis. And it's very important to distinguish the two because AL amyloidosis can be a malignancy, associated amyloidosis, multiple myeloma. And so we have a very strict algorithm that we cardiologists follow if we're contemplating the diagnosis of amyloidosis. If we suspect amyloidosis, patient comes in, heart failure with preserved ejection fraction, LV wall thickness of around 1.4. We do echo, and there's a strain pattern that looks suggestive of cardiac amyloidosis. Then we send them to get blood work checked, kappa lambda light chains, 24-hour urine studies for monoclonal protein. And at the same time, we also look for ATTR amyloidosis with PYP scans. Cardiac MRIs have become superb in diagnosing cardiac amyloidosis. So it's almost every patient with heart failure that I see, I will send them for at least one cardiac MRI to see what the heart muscle looks like, what the problem is. And so it's been very helpful. And we have new treatments for cardiac amyloidosis. We have stabilizers that stabilize the transthyretin protein. And so we have silencers. We have CRISPR, which is a gene editing therapy. So because of a lot of the therapies available now, we're very excited, and so we tend to diagnose a lot more patients with cardiac amyloidosis these days. So that's it. So heart failure is a big problem, right? I mean, we have 6.7 million patients currently with heart failure, only to get to 10.3 million in 2040, I'm sorry. And that's mainly because even though we've made huge strides in managing coronary artery disease, obesity, diabetes rates continue to go up. And so the heart failure with preserved EF certainly is overtaking heart failure with reduced ejection fraction. And so, I find that it's very important for all of us to look at our patients more closely. And for you, you're in such a great position to actually help those patients with pre-heart failure or the stage A heart failure, where you can manage those risk factors, albeit it's not easy to do. But that's the role that I think we all should play, is a preventive strategy rather than a treatment strategy. So, well, thank you so much. Sorry about the glitches in, next slide.
Put it to work. Maybe by the afternoon we can show it to you. Otherwise, hopefully it'll be on the slides when we send them out.
Okay, great.
Because I was able to run it at the house.
Yeah, I could run it here, but I guess.
Yeah, sorry about that, guys. We have some questions. We have about 10 minutes for questions, and then we're going to do lunch. Just to prepare you, we need everyone to exit this way for lunch. Otherwise, we'll run over each other, and then take a right and go down the buffet and come back in here. Okay?
Thank you very much. Great presentation. Two questions. One is about the medication management. So all four categories that are listed, to some degree or another, are potassium sparing. Do you get concerned about somebody, especially with chronic kidney disease, who has higher potassium? In that case, which one of the medications would you sacrifice or not add? How do you manage that? Second question is, a lot of patients have that perception that when they have swelling, when they have edema, one of the solutions is to drink more water. Where did that concept come from? Why is it so prevalent and entrenched in the mind of people? How can we just reduce it? Tackle it?
Yeah, great questions. So your first question, yes. So which medication do we sacrifice if we have tendency for hyperkalemia? Because the Entresto, the RAS inhibitors, and the MRAs can increase the potassium. And so I think the first one that we sort of sacrifice is the MRA, the spironolactone eplerenone. Not that because it doesn't have good data. It has excellent data, but it's hard when you have a patient with a potassium of 5 and you're like, okay, this thing's going to make your potassium go to like 5.8, right? You don't want them to die from hyperkalemia. So I think that's usually what we cardiologists do, is say, okay, we'll start you. And I actually start everybody with like all 4 really low doses. So I'll do carvedilol 3.1 to 5. If they have a decent blood pressure, I'll do Entresto 24-26, and then I'll do the SGLT2 inhibitors. And then I'll bring them back. If I feel like, okay, that's going to hit their blood pressures quite a bit, the electrolytes are probably going to be a little off, I'll bring them back in a week or two, check the labs, and then I'll add half, like 12.5 of spironolactone if their blood pressure can manage it. So, but if they have renal dysfunction, if their creatinine's like 2, I don't use the MRA because I'm very worried about hyperkalemia in these patients. So, and the second question about water and heart failure, it's a tough one. I don't know where it comes from. I think people in general have been told you've got to drink a lot more water, especially if you have kidney dysfunction. what I tell my patients is that you drink to thirst. Don't overdo anything. Don't think like if I tell you you have to limit yourself to 1.5 liters or 2 liters a day, that you have to drink 2 liters a day. That doesn't mean the same thing. But I tell them, drink to thirst. If you're thirsty, drink the right kinds of fluids, but don't overdo drinking. I find it not so much of a problem with my female patients because they don't drink any water anyway. They don't want to go to the bathroom. But the male patients, you have to just talk to them about that misconception that you don't have to overdrink to protect your kidneys or anything. Your body's going to do what it's going to do. Just keep hydrated. So that's usually a technique I use to get them out of that mindset.
We've got the video queued up, so why
okay.
don't we take a second to look at it?
Sure.
All right, guys.
It's probably way better than my explanation. And so basically this is that catheter. We were talking about heart failure with reduced ejection fraction and patients with severe mitral regurgitation. So we take a catheter across the interatrial septum, and then we cinch it and put this little clip. It's called a mitra clip. We have a tricuspid version as well, but we cinch it right in there. And then it just stays there. We put one clip for most people. Sometimes we need to put a second clip. But when we put that clip, you can see before that, it was a lot of mitral regurgitation, and then we reduced it to mild or moderate. What we are looking for is to reduce mitral regurgitation, but not create mitral stenosis. So it's always that sort of dynamic. So we do that at Roper. We do heart biopsies at Roper. We do the cardiomems at Roper. I mean, Roper, we've done a lot of things. We try not to refer our patients out because we know the importance of, patient-centered care within one system so that they're not confused and we're not looking at Trident records and MUSC records. So we've been able to provide our patients with the most cutting-edge technology and hopefully more to come.
Let's take one question and then we'll go to lunch.
What about alcohol intake and heart failure?
Yeah, so alcohol is a direct toxin to the myocardium. Okay. Any form of alcohol has not shown to be a health benefit. The resveratrol and all the story, you've got to have I think 2 pounds of resveratrol to be healthy for you, so to speak, right? So alcohol is mainly for social enjoyment. People shouldn't be drinking alcohol alone anyway. If you are going to drink alcohol, you should drink with somebody. That's kind of where I think the benefit of alcohol comes from these studies. But in terms of the cardiac function, it's a direct toxin to the heart muscle. So it can cause an alcoholic cardiomyopathy. And so we do see that, there are some patients who will come in, they've had, alcoholism for a long time, develop a cardiomyopathy. Generally, it can be reversible, although in some cases, if they've been scarred up quite a bit, it's unlikely. And then for heart failure with preserved ejection fraction, the main issue is development of arrhythmias. So alcohol predisposes patients to develop atrial fibrillation. We have something called holiday heart, if you're aware of it. People don't drink the whole year, and they drink it up during the holiday season. And we have, usually it's some young person who shows up in the ER palpitating and atrial fibrillation. So alcohol contributes to atrial fibrillation, which then can cause heart failure. So in that sense, it has an indirect effect on the heart.
I just wonder if it was an important part of counseling your patients with heart failure is that, you've got your core drugs.
Yes.
Is that the fifth aspect?
Yes, absolutely. I mean, when I do my initial history and physical, I never skip the social, and I always ask, especially in the Charleston area, how much do you drink? And it is so amazing to see. They're like, not much. I'm like, how much is not much? And it's usually 4 drinks, and I'm like, oh my God, so we have to really take it seriously around here because I practiced in Maryland for a long time. People don't smoke there, they don't drink there. So you kind of sort of ask the question, but they're not doing it. But in this area, it's very important. Alcohol is a big question, and of course I say no amount of alcohol is good for your body. No amount of it. But if you have to, you can drink 1 drink, and it has to be with others. Because that's where the social benefit of alcohol comes from, is that, you know, you're with other people, you're talking. That's important for your brain. That's important for your lifestyle. You shouldn't be sitting in front of the TV and just drinking 3 or 4 beers. That's not going to help your outcome.
Well, that's good advice.
Thank you.
So if you guys would like to go get some lunch,
Thank you.
come on out this way. And Dr. Pinto will be available if you have a couple of questions.